This program is brought to you by Emory University.
Good morning, everyone. Thank you for joining this morning. It is my absolute pleasure to introduce one of our speakers this morning who needs no introduction and is one of us and has been at Emory for a few years, I think. Dr. Clements went to Georgia Institute of Technology and then Augusta Medical College in Georgia, did his internship and residency at Grady, followed by cardiology training at Emory. He joined the U.S. Army Medical Corps, where he earned a meritorious service medal. He's received many prestigious awards, including the Lifetime Achievement Award from the Georgia ACC. There's a chair honoring Dr. Clements in the Rollins School of Public Health. He's known for his clinical acumen, his kind and benevolent bedside manner to patients. Patients love him, trainees love him. He has a passion for teaching and has published a digital book on echo recently. He's going to talk to us today about anatomy of a murmur. Thank you, Dr. Clements.
Thank you, Pooja, for that kind introduction. So as everybody's having a sip of coffee and waking up a little bit, I'm going to show you a little, what you might call a little teaser here that I've had in my collection for a number of years, and very few people recognize this. And it's an EKG. So here's the EKG. So in your mind, I'd like for you to look at this EKG and imagine that you are an interventional cardiologist. If you look at this EKG in the emergency room, it says, I know what that is. We're going to the cath lab and we're going to take a picture of the culprit vessel first, so we can get that going and then head down to the other vessel later. So if you look at that, you can always use the help of the computer, which tells you this is an acute MI, and even tells you where it is. There's something anteriorly that's in trouble. So if you saw this EKG in the emergency room, the patient was having chest discomfort, then you would say, okay, we're going to the cath lab, we're going to shoot the culprit vessel first. Here we go. Which vessel would you like to shoot first? In your mind, you can answer that question. So, okay, the answer is, your answer is shoot the LAD first. Well, there's SC segment elevation in the precordial leads. Notice that the R waves are okay. Notice that they're probably small Q waves inferiorly, 2, 3, and AVF. And so you're choosing the LAD. So you put a left jut in, you shoot the left coronary artery. And here it is. And to your surprise, the left coronary artery is okay. But whoops, maybe we better look at that EKG again. What is that? Well, it's anterior segment, anterior SC segment elevation. That means the vector is pointing anteriorly, and there are things anteriorly other than the anterior wall, and they happen to be the right ventricle, and you inject the right coronary artery, and there's a culprit vessel. It's the right coronary artery. If you want to take another look at that, there it is. So maybe you're in the emergency room, you do that, you can really make some points with your friends. If you'll identify that that is probably a right ventricular infarction and not a left ventricular infarction. Oftentimes, these are associated with small changes in the inferior lead, sometimes not, depending on the size of the artery and its distribution. So remember that as a little pearl at the beginning of this presentation. So we're going to talk about a murmur. This, I was stimulated to do this by a wonderful gentleman that I've known for a long time. And he developed a murmur. And I learned one day that he was in the hospital. I learned that he was in distress. And I will say I kind of knew what was wrong with it. And so I sought him out, and I'm going to show you his situation in a few minutes. But another patient and another situation, I want you to listen to that. I hope you can hear that. Way back in the early 1800s, James Hope describe these kinds of murmurs as purring. They've been described as honking sometimes, when they have a little different quality. When you go to the aortic valve, they've been described as cooing. So I'm going to show you the patient whose murmur that was in a few minutes. I'll even tell you how I recorded this if you'll keep it a secret. So remember that mitral regurgitation is a holosystolic murmur. And it's holosystolic to the point of enveloping aortic closure. So if you say, what is systole? Well, systole can be defined a number of ways, but systole may be all the actions that take place between mitral tricuspid closure and aortic pulmonic or pulmonary valve closure. And after that, there's a little gap on this Wiggers diagram between aortic closure and when the pressure is reversed in the left ventricle and left atrium. That is called the isovolemic relaxation time. So holosystolic murmurs are caused by MR, TR, and VSDs, and ejection murmurs. As you know, you listen to aortic stenosis, ASPS, and HOCM. And it's important to remember that. So that's your definition of a holosystolic murmur. So in the echo lab, if you happen to have a jet radiating up by the aortic valve, that is an anteriorly radiating jet, and you put your M mode cursor here and turn the color on, that little point is aortic closure. And you see this jet continuing after aortic closure and ending right here. So at that point, flow is reversed and diastolic filling occurs, but right during that, that's another measure of isovolemic relaxation time. If you run out of things to do in your spare time, you can study the Wiggers diagram. You'll learn a lot from that. And you can superimpose this image on that and understand that after aortic closure, this jet of mitral regurgitation continues and ends when those pressures reverse in the Wiggers diagram. And this, of course, is a graphic example of mitral regurgitation and a holosystolic murmur that might be produced by that gradient. So this gentleman was a long-standing patient of mine, and he taught me so much.
So John,
he came in one day and he told me this. So let's listen to him a couple of times.
Then I could hear a murmur in my ear. When did you start hearing the murmur? About 3 weeks ago. Wow. Have you been short of breath? How long have you been short of breath? About 3 or 4 weeks. 3 or 4 weeks. Okay, very good. So John, what did you tell me yesterday when you walked into the exam room? That I could hear a murmur in my ear. When did you start hearing the murmur? About 3 weeks ago. Wow. Have you been short of breath? How long have you been short of breath? About 3 or 4 weeks. 3 or 4 weeks. Okay, very good. So John, what did...
So you heard him tell me that he heard a murmur. So I'll tell you that I have had patients tell me that more than once. I've heard of other situations in which patients hear things going on in their chest. For example, I recall one time a patient with a sinus of Valsalva aneurysm, and it ruptured, and the patient said, I felt a pop in my chest. So there are various events in the chest that translate to the patient hearing something. So just a little review of this situation. A long time ago, he had a supracrystal VSD. If you look over to the left, you'll see a little diagram of the cross-section of the aorta and see this red arrow here is a direction of flow right under the PV and right by the right coronary cusp of the aortic valve, where the very high outflow VSDs occur. They occur so high that they compromise the integrity of the aortic annulus, particularly the annulus that holds the right cusp of the aortic valve. Now, he had a bicuspid valve, and this happened despite his having a bicuspid valve. So that valve leaflet can prolapse down, obstruct the VSD, but it results in aortic regurgitation. Now, pediatric cardiologists know that, and as they see patients with this entity, they will make a move earlier than later. Probably does not lend itself much to an intervention with a plug, but it's a definite entity. And as you may encounter one of these individuals in your career, you've got to think about this complication. So don't particularly like this diagram because it depicts this as under the PV, but it is also under that right coronary cusp. And down at the bottom, you can see all the various consequences of that, with the aortic valve prolapsing down into the VSD, becoming aneurysmal, all kinds of complications in this part of the cardiac skeleton. So if you identify one of these people, you got to anticipate this anatomy, anticipate this pathophysiology. So this was his echo way back in 2003. So we saw this VSD, which is up here, and all the aortic regurgitation with two jets there. He was beginning to have symptoms. So we called the surgeons, and the surgeons repaired the VSD and replaced the aortic valve with a mechanical valve. So that was the saga of that. Now, time went on. He was a big gentleman, as you probably could see in that video. His father had had coronary bypass. He had risk factors, developed symptoms that sounded like angina, so we did a cardiac cath. And unfortunately, he had triple vessel disease. We had scheduled him for surgery. Something happened to him in the interim, hardly with any chest discomfort, but he started developing problems with heart failure. And as it turned out, he occluded his circumflex. We let him recover a little bit from that and did a coronary bypass on him to all those areas. So after the bypass, he had a scar back in his posterior wall. And unfortunately, he started having episodes of VT. So our electrophysiology friends got involved, and this was the monomorphic VT. So they did an ablation and subsequently put in a bi-V ICD. So we were looking for some stability after that. The VT settled down, and then about a month later, he told me about this murmur that he heard and the fact that he was much more short of breath. He heard the murmur. So when the patient hears a murmur, that means it's pretty loud. It's getting up there to grade 5 and 6. And that caused me concern. I of course,
So, John, what did you tell me yesterday when you
listened to this carefully?
That I could hear a murmur in my ear.
When did you start hearing the murmur?
About 3 weeks ago.
Wow. Have you been short of breath? How long have you been short of breath?
About 3 or 4 weeks.
3 or 4 weeks.
So this did occur about a month after his ablation. And this is his CW Doppler. You can see that this murmur has vibrations that have symmetry to them. And that gives you an idea of what the physiology, pathophysiology might be here. not exactly musical, rough, but it, when you look at the CW Doppler, you see it does have symmetry and all these little vibrations that have a similar frequency. So what you see next is his mitral valve, and notice that there's a small area that must have a ruptured cord to the anterior leaflet there. On the right is the jet of the mitral regurgitation. You see the pisa forming and the jet, and that is associated with a loud sound. This kind of anatomy on three-dimensional echo looks like this. You have to look, because it's moving fast, you have to look at this quickly. It's right in the A2P2 area. Now, he already had coronary bypass once. He'd had ablation. He had a low EF. And we had to figure out what to do next. I was concerned about his having another operation. So we looked at it from a standpoint of whether or not we might do something from the structural standpoint with this. And we adjudicated that a bit. And we came to the conclusion that we ought to try this. So as you look at that image, if you've seen this before, there's the mitral clip. After a lot of maneuvering, we maneuvered it right over that area of interest and dropped the grippers and captured the ruptured cord and attenuated the mitral regurgitation a lot. So what's the mechanism of this? Well, this is not that patient, but it's another patient. The mid portion of the anterior mitral valve leaflet was ruptured here. There were vibrations back in here. Actually, the phonocardiogram showed this high frequency vibration there, and that corresponded on the M-mode echo when you turn the sweep speed up to the vibrations on this portion of the leaflet, which corresponded anatomically to that. So this is almost exactly what we had otherwise. So we put the clip on there, made him better, but not dramatically better. So what's the mechanism of this vibrating structure? In the mitral valve situation, the mitral valve, if there is a flail, and we use the term flail if there is a ruptured cord, like a flail sail on a sailboat. That means a tether is ruptured. And if it prolapses, we don't call it flail, we call it flail if something is ruptured. Usually you can see that up here. In the aortic valve, usually there is eversion of a cusp. It used to be described in syphilitic aortitis and the aortic valve involvement. The cusp would evert, and you hear these musical diastolic murmurs. In the situation here, you hear these vibratory holosystolic murmurs of the mitral valve. So that patient was someone who de novo ruptured the cusp to the anterior leaflet, and he heard the murmur, and we knew what was going on just from listening to his story, as you heard. And you don't get murmurs like that with the tricuspid valve usually. As a matter of fact, reminding you that tricuspid murmurs you can hardly hear anyway, especially if they're wide open. And the diagnosis of tricuspid regurgitation depends very much on what the neck veins look like. You can tell about that a whole lot. Look at it on the echo, see a tremendous amount of tricuspid regurgitation, but you don't hear much of a murmur. So you can remember that. So that's the first patient who had a loud murmur that he heard. Now this gentleman, in this state, in a wheelchair, on oxygen, when I happened to be in an office in North Carolina, was wheeled in to the office as the last person I was supposed to see in the morning. And he was 90 years old. He was a butcher, and he had developed acute shortness of breath. He was in the hospital. They wheeled him out of the hospital over to the office where I was, and they rolled him in just like this. And the story was from him that he had been turned down for surgery at a hospital south of where I was. And he knew anyway that one of his church friends recently had a similar situation and had surgery and subsequently died. So this was a little desperate. He had been at home and went back into heart failure and pulmonary edema, got back in the hospital, had to have IV Lasix. And they wheeled him over to my office. So in seeing this, I pulled out my stethoscope, and he had a very, very loud murmur that you can imagine the physiology of it. It was heard at the apex. It was radiating up toward his neck. It was holosystolic. There was a thrill associated with it. And he was a tremendous gentleman. He was just sitting there telling me the story. So I kind of knew what the situation was. So I said, well, maybe we can help you. So let's go down to Atlanta. So that day I arranged for him to get in an ambulance out of the hospital and come down to Atlanta. So you can imagine what our thoughts were. So what do you expect to see on his echo? Notice I showed you that the murmur was radiating toward the neck. So here's what you see on echo. So you have to watch these 3D echoes because they move fast. So you notice that is absolutely classic P2 mitral valve prolapse. And if you look up there, the cords are ruptured. So this is a P2 prolapse with a flail leaflet. And that produces very loud murmur. If you've seen this before, you know that the murmur can be heard up in the aortic area because the jet is going to radiate up like this. That's the aortic valve up at the top there, oriented at 12 o'clock, and this is the surgeon's view of the aortic valve, of the mitral valve with the aortic valve up at the top. And that's a flail P2 segment with ruptured cords that you can see there. Now, reminding you that when the anterior leaflet is in trouble, like the first patient we saw, the jet tends to radiate posterior. You may see it, you may hear it in the back. And when the posterior leaflet is ruptured, or there's a flailed segment, the jet radiates up behind the anterior leaflet up toward the aortic valve. And sometimes, if you're not careful, you will think the patient has aortic stenosis and not mitral regurgitation. So keep this in mind as you see people with mitral regurgitation. You hear that and you say, well, this patient has aortic stenosis, and you need to feel the carotid upstroke. And if it's brisk, you need to start thinking about something else. So, here I was in North Carolina with this little man in my emergency room. So I was calling down to try to anticipate what we might do. What might we do in the cath lab? We'd like to know that his coronary arteries are okay. We'd like to put in a swan and let it float out into the wedge position. If we did that, what would we expect to see? So I'd like you to know this, and here's what you'd expect to see. So if you make these recordings carefully and you put a catheter in the left ventricle, maybe a pigtail, and you put a swan in the pulmonary artery and let it float out into the wedge position, and carefully look at the timing and know that that's not the PA tracing. That is the wedge tracing. You see this V peak over here at or just beyond the downslope of the left ventricular pressure tracing. This is both at 50 scale, so you have to set your scales up right and make them equal. So here we have a giant V wave, a giant V wave. You can see systole there and diastole after that. You naturally have a gradient because there's so much flow into the left atrium and so much flow back. And if you're watching your swan and you have your finger on the syringe and you move the little clip and let the balloon down, you'll see that about right there it'll make a transition, and that is the V wave. It's almost as high as the pulmonary artery pressure. That's pulmonary artery pressure over there, and the balloon went down right there. So that looked like this as you blow it up. And that V wave reached 60 millimeters of mercury. So there's some little rules. If you read Grossman, you'll find that the V waves at about twice the mean left atrial pressure suggest severe MR. If they're 3 times the left atrial pressure, they suggest for sure MR's presence. Have to remember, if you have a very large left atrium, it buffers the MR pressures that generate in systole, and you might not get a big V wave. So what was our goal? There I was in the office with him in North Carolina. Went, what in the world am I going to do? I've got to get this man better. He's been turned down for surgery. His family's hovering around. He's 90 years old. He otherwise is a vigorous gentleman. So our goal was to create this. So we didn't do, Dr. Alfieri, he did not do this procedure. I will give Dr. Babilaris credit for doing this procedure, but we put a clip on his mitral valve and we created a double orifice mitral valve. And we clipped right at that flail leaflet of the mitral valve and attenuated his mitral regurgitation significantly. To get you oriented, this is the surgeon's view. If you'll look over here, the left atrial appendage is at 9 o'clock. The aorta is at 12 o'clock. And we helped him and he went home. And to tell you the truth about it, he has done miraculously well. You can imagine what his church members thought when he showed up again in church after they had lost one church member from this. And so he, needless to say, became an advocate of this procedure and what we had done to it. So to change the subject, we're going to talk a little bit now about prosthetic mitral valves. And one of the mechanisms of prosthetic tissue mitral valves dysfunction is that they can look pretty good for a number of years. And then suddenly something happens. And usually what happens, that stage of the game, amongst other things, is their mitral leaflet at the commissure, where all the stress is, becomes disrupted. And that cusp prolapses. And you get a ton of mitral regurgitation. This is the atrial surface of that tissue valve in the mitral position. Now, and some other things that can happen to these mitral valves, and you know, you see people in your clinic that have tissue valves in the mitral position, the aortic position, the tricuspid position. So in your mind, you have to say, okay, when we get beyond 10 years, and hopefully we get to 10 years, between 10 and 15 and 15 to 20, something's going to happen to this valve. So I need to be ready to deal with it because we have all kinds of ways to deal with it nowadays. So you can anticipate this. If they come to your office and they have no systolic or diastolic murmurs at the apex, so well, they're doing fine. The leaflets must be mobile. I'm proud of the way they're doing. But occasionally you'll get into other complications, like up at the top right, you see that mitral porcine prosthesis has developed endocarditis. This was a staph organism. Just about obstructed the whole thing. This was a disastrous issue, but they can get endocarditis. They can fill up the mitral orifice. They can also obstruct the mitral valve orifice. That's unusual. It makes you think of fungal endocarditis, where the vegetations are large, but this one was a staph. So we learned a long time ago that it's not good to put a tissue valve in a teenager. I mean, we thought we had the ideal situation. So we put a lot of tissue valves in teenagers when they had bicuspid aortic valves or, for example, on the left, this is not a teenager, but it is an adult who had this valve in the mitral position. And when he got beyond 10 years, his valve started calcifying. This makes you think about people on dialysis, who calcify things. So sometimes just in the natural history of this valve in the mitral position, they calcify the valve. As you look at a valve like this and anticipate what we might do, say, can you imagine putting a TAVR in the middle of that valve? And what might that do when you expand the balloon and you crush that calcium? Might it all be pushed up against the sides, or might you embolize something? Well, certainly you worry about embolizing something, despite the fact that we have some cerebral vessel protection nowadays. Calcification is an issue. As you see, we made the decision to take this valve out and put another one in. So too much calcium, that's an issue as part of the degenerative process. Now, the valves that have pericardial leaflets, this is a pericardial valve, looks perfect. Looks perfect. It had been in about 11 years. Looks perfect from this side, but notice we've taken it out. So Dr. Guyton told me when he took this valve out, he says, it looks good, but if you touch the leaflets, they don't move. And the calculated mitral valve orifice is about what you see there. So pericardial valves may degenerate simply by the leaflets becoming stiff. You can understand also that this commissural point is really a stress point here in this valve. And the other patient that had the ruptured leaflet, the rupture started right here. And this commissure pulled down. To remind you that these pericardial leaflets, this is not the scaffold of the valve. This pericardial cusp is tailored and is sewn in, so there's a suture line all along here, all the way up to this commissure here. It's individually sewed in, individually tailored, and one of the complications of that valve is it really thickens up a little bit, but it becomes stiff. So that's a pericardial valve. Now, this is an unusual complication of that. Surgeons know that it's important to preserve part of the mitral valve apparatus when they put the valve in. We learned that the hard way a long time ago, and our surgeons were some of the leaders in making this determination and trying to figure out some way to preserve the integrity of the mitral valve apparatus in the setting of replacing the valve. So if you look at this carefully, this is a pericardial valve. They're the pericardial leaflets. They're the pericardial leaflets. There's a commissure, there's a commissure, there's another commissure over here. But the surgeon has left the anterior leaflet in and the posterior leaflet in. And it looks like they left the whole anterior leaflet in. It kind of wrapped around the prosthesis. And what you wound up with was the leaflets kind of stuck to the commissures. The leaflets contracted down, and the orifice of the mitral valve was very compromised. The leaflets were okay behind that, but the leaflets of the old valve were causing mitral stenosis. The consequence of that is the valve has to be removed and replaced. So this is a rare complication of simply putting in a valve and actually leaving too much valve tissue in there. Ed Shin taught me something about this. I said, what do you do, Ed, when you replace a mitral valve with the leaflets? He said, well, what I do is I make an incision in the anterior mitral valve leaflet like that, and I move the whole anterior leaflet back in the back and plaster it against the posterior wall and get it out of the way. Therefore, you retain the integrity of the mitral apparatus, although it's just pushed posterior. The anterior leaflet does not have a chance to like grow around the valve itself. I don't have to cut any cords with that and preserve the entire apparatus of the mitral valve. So that's Ed Chin's drawing that he sent me. And that taught me a lot right there. That's his personal way of doing it. I think that's the way a lot of surgeons do it. So now we've talked a little bit about the generation of tissue valves. As you see people in your office who have tissue valves, particularly in the mitral position, they're doing well at 10 years. They may not be doing well at 12 years. Those are the kind of things that you look for and you alert. And once you hear a new murmur or once you see an echo on this patient, you know what's happening. So this is another, I should say, pet patient of mine. About 10 years before, she'd had her mitral valve replaced for endocarditis. And at her 6-month visit, she comes in, she says, you know, I am short of breath. And I said, in my mind, I said, oh no. So she had this echo, and I look in here at the mitral leaflets. Mitral leaflets appear to be thickened. And there's a gradient there that was mean of 12. You see the candle flame there. With mitral stenosis, you see the mean gradient down here was 12. So what are we going to do about that? Actually, this was her second valve. And she had taken warfarin for 3 months after her valve was inserted. And here we were 2 years later, and she's telling me she's short of breath. So that was a bit distressing to her and to me. But if you've had a little experience with this particular echo appearance and this particular scenario, you kind of know the next move to make, or you talk with a surgeon and he'll tell you the next move to make or whatever. So what would you do? Take the valve out, put a tabber in the valve, worry a lot. And so you put them on warfarin. So we put her on warfarin. She didn't like it, but we put her on warfarin. And she called me 2 weeks later, and she said, I am much better. And then I said, well, I want to see in a couple of weeks, we're going to do an echo. So this is her echo about 5 weeks later. See, her leaflets are thin and are moving, and her gradient down at the bottom was 3, and the candle flame is gone. So she had thrombosis just behind her anterior leaflet, just behind the leaflets of all the leaflets of her prosthetic mitral valve, and they went away, and it was thrombosis of the valve. Did she have some sort of hypercoagulable state? Well, maybe she did. We couldn't document it, but she continues to ask me how long she has to take warfarin. And I've consulted with Robert Guyton about this, and our answer is the same. Keep taking. So this is a patient of Dr. Williams that I got involved with, and a very nice gentleman, a pharmacist who started having difficulty with shortness of breath after his tissue valve in the mitral position. And this was in 2011. Notice that behind this leaflet seems to be something. Either the leaflet is thickening up or something. You see the candle flame forming down the left lower quadrant. Notice that, there's a big thrombus up in the left atrium. You'll hardly ever see a thrombus like that unless you have mitral stenosis. See the orifice down in the right lower quadrant with tissue within tissue valve. Has about a third of the orifice that it should have. So anticipated what to do about that. We actually replaced that valve later after some time with warfarin. And then on his new valve, it tended to come back and get thickened and developed a gradient again. So there was no thrombus associated with this. The left atrial thrombus had resolved. We didn't think we wanted to operate again right then, so we decided to do this. So this is a second valve that he had. And notice down here that there's something going on in the mitral valve. There's a balloon going up, and we put him in a TAVR in his mitral valve, a valve in a valve. So these valves can thrombose down the line, despite having Coumadin initially. We still haven't figured out exactly what kind of approach we should have with anticoagulants to these valves. One word about mechanical valves. This was a long-standing patient of mine that had a tissue valve in the mitral position. He had a second operation. Her valve lasted 23 years. And so in her mid-50s, she gets a mechanical valve. Now, when you replace the mitral valve, the mitral annulus takes a hit. And it becomes scarred and weak, and it's hard to sew things in. The surgeon struggles with it. They may not tell you about it, but they struggle with it. But you wind up oftentimes with these leaks, and you wind up with these plugs. So the second time around mitral surgery is not something to be taken lightly. And this is, in my opinion, a pretty common situation with the second time around. If something's wrong with the patient, you always look for this. You can't see it on transthoracic, and you have to look for those PVLs. They may have hemolysis, can't see it on transthoracic. They have PVLs that require plugs. Certainly don't want to operate again unless you have to. So the last patient is, I'd encourage you guys to carry your stethoscope in your pocket. I will tell you that there are those out there that don't carry the stethoscope in their pocket. But this long-standing patient of mine, the other day was in the hospital. It was his murmur that you heard to start out with that I recorded on my phone. He was in breathing distress. He was in atrial fibrillation, which he hadn't been in years. His valve had been replaced in 2007, and this was just last week. And we put the CW across it, and we saw these rainbows of echoes. And I said, oh, well, I know what that means. And that means that some of these frequencies are all the same. And when you listen to this, it has a high-pitched kind of musical in the background. It has a lot of roughness to it, but it has a kind of a musical murmur in the background. It's loud. It was grade 6. You can hear this with your stethoscope off the chest. And he was 101 years old. In the next couple of weeks, he would have been 102. So the first thought is that we should not come close to him with a catheter. And then after a couple of days, he went back into sinus rhythm and started looking a little better. So we then started making arrangements maybe to do something to him. And you probably know what I'm thinking about, but we made plans to do something to him on last Monday. And over the weekend, he kind of lost it from the standpoint of his mental status. He developed myoclonic jerks. And we just did not think that we could do that to him in his current state. If he improved, that we would do it. He did not improve. And we never got around to doing anything. So this is the way his echo looked. If you'll look at his ventricle, it's very dramatic in that it's hyperdynamic. His valve leaflets are not particularly thickened, but at least one of them is prolapsing back. And if you remember back, that tissue valve that had the ruptured valve up at the commissure, I'm sure it looked exactly like that. This is a setup to do something about it. There's the mitral regurg, which threw him into pulmonary edema. There's a vibration there that I'm sure was an equal frequency to the murmur that you heard. And we have in him, of course, the valve gave us a scaffold. So you need a scaffold, like the mitral annulus can be a scaffold. It's incomplete and it's got the anterior leaflet out there in our way, and it's caused us to have to do lampoon procedures on people, but there's a scaffold. So that's a setup for doing what we need to do. I'm sure you know what we're thinking about. So here's another patient that had a similar situation with a very stenotic valve. Here we go with the balloon here in the right upper quadrant. And here's what it looks like afterwards, a valve in a valve. So we had that in mind, although unfortunately we never reached that point in this patient. This is what we were trying to do. You have the scaffold there, you have your markers, and you know where to place your TAVR valve and where to put the tips of the valve and how to adjust it as you're blowing up that balloon and the results you're looking for in the right lower quadrant. Notice that while we're doing this, we're rapidly pacing, making the cardiac output like go down to almost nothing. Otherwise, hard to squirt that valve right out of there. So in conclusion, you have to remember in these people that come into your office with tissue valves in the mitral position, they may last 9 years, 11 years, 23 years. We don't know, but somewhere in that range, hopefully, unless they thrombose early on. So if a patient complains of shortness of breath and has a prosthetic valve and a tissue valve in the prosthetic, tissue prosthetic valve in the mitral position, beware, because you should know the possibility. First thing you do is you use your stethoscope, you get an echo, you see nothing, you get a TEE. You know the hemodynamics with a large V wave. If they have hemolysis, you need to look for a paravalvular leak, and you need to know what your options are. So with that, we'll stop. And I hope that this has broadened the spectrum of your knowledge about people who have tissue valves in the mitral position. Thanks so much.
Thank you, Dr. Clements. That was absolutely fantastic. I just love the cases and the images. I just expected to learn a lot, and I definitely did. And a lot of it was we relearned, things that we had forgotten. So thank you for that. I do have a question about, that case that you showed with the woman who had thrombosis of her mitral valve. That situation makes me very nervous because I never know, when you put people on warfarin, whether that's going to work or not, and whether to go ahead and send them to the OR to get that taken care of. It's a little bit like when we see endocarditis on valves and we say, we'll put you on antibiotics and we'll watch to see whether it will help or not. Can you tell us, in your experience, how often does this end up not working? The strategy of, putting anticoagulation, people on anticoagulation, and then the thrombosis doesn't go away.
Well, first of all, thank goodness this is not a frequent complication of this valve. Number one. Number two, it does occur occasionally. Number three, I have seen someone who did this at about 6 months and actually had a very bad outcome because she didn't recognize what was going on. And this was a dramatic response. The other patient had more thrombus and had a propensity to have more thrombus. So it's not a very common thing. I think the odds are in our favor from the standpoint of it responding, although the other patient that I showed, which was Dr. Williams' patient, we struggle with that and struggle with that left atrial thrombus. And somehow I got through it to the point of having no thrombus and put in a TAVR. So that's a big, big leak. If you talk with the surgeons about these valves when you put them in, assuming they don't have atrial fibrillation, they have sinus rhythm, and they're not anxious to take anticoagulants, then they will say that their literature says to give anticoagulants for 3 months. Well, I'm not sure that we probably pulled that number out of the hat. But down the line, we have to be alert. It seems that this is not a common thing that results in embolization. It just results in obstruction. And this occurred in this person despite having anticoagulation early on and getting 2 years under her belt before this developed. And she recognized, she's a runner. She recognized these symptoms. She reported them, and I dreadfully looked at this and crossed my fingers and gave her warfarin, and it worked out all right. So the answer is, I'm not sure, but we have to be alert to this. We have to know that this kind of response does occur, and we have to hope for it. Doesn't always work. And you hate to send them for a third surgery.
Yes. Well, with coronary disease, I feel like we have all kinds of things that we do to kind of help people reduce their risk. But I just feel like these mechanical things with the valves, it's very scary because, you can have patient doing fine and then all of a sudden they're short of breath and something's happened to their leaflet. So I love these pictures. Let's see if there are any questions or comments from the audience. Everybody's processing these images.
Okay, well, I hope that this helps you all. And over the years as I've accumulated these experiences, it certainly has been valuable to me. This is not all the things that can happen, but these are the common ones. You have to be alert to them. And as time goes on, there's a large population of people out there who have these valves in. That one about the pericardial valve that thickened up taught me something. When Bob Guyton said, look at this valve, looks perfect, and the leaflets are very stiff. So thanks very much, Pooja.
Thank you so much, Dr. Clements, for your time. And thank you, everyone, for joining. I will see you next week.
The preceding program is copyrighted by Emory University.